Well, good evening and welcome. My name is Dr. Randy Fink, and I am the Clinical Director of IVF Services here at CNY Fertility, Colorado, and also the Medical Director at the Miami Center of Excellence in Miami, Florida, in the CNY Monitoring Center there. I'd like to say good evening to everyone. We're so happy to have you all with us here. Everybody seems to be joining here all at once. Gosh, so many people, too many people to say hi to, except that, gosh, I'm seeing some old friends. Everybody just kind of jumping right in. Hi to Lauren. Hi, B Mush. Nice to see you guys. Hello, of course, to Amber, to all the nice people that we saw here in Colorado this week who joined us either for a retrieval or a transfer, or who we spoke to on the telephone for a consultation. Sure is great to have everybody with you. It's with us here. It's a little bit after 4 p.m. In the Mountain Time, which makes it 6 p.m. on the East Coast, 5 p.m. Central, and of course 3 p.m. for our friends on the Pacific Time. Well, tonight we have something special on Fertility with Fink and Friends. We've got, first of all, broadcasting live, of course, to our CNY Nation through Facebook and LinkedIn and YouTube right here. We've got two different Instagram feeds. So looking all around, we're just trying to make sure that we get some eye contact with everybody, because that's just important. Hope it's a good Tuesday for you. Tonight, we're going to talk about sex. Before we kind of launch into this and what kind of brought me to this topic, I would like to say also that I learned last week that my own parents, my mom and dad, were happily watching last week's program from Mobile, Alabama. So I would like to send out a special hello to mom and dad in Mobile, Alabama. However, I think they're not watching tonight because I told them you are not allowed to watch tonight because we're talking about sex. And that, frankly, would just be wrong. So we need to, I got to draw the line someplace. I also wanted to be very careful here that we don't violate any of the social media norms or use policies by talking about these things, but we're talking about them in a clinical way. And so if you saw my advertisement, Dr. Jazz is from Mobile. Howdy. If you saw any of the advertising, we said intimacy and you, because I didn't want to say something that got Instagram or somebody upset with us. But I got several questions to me through Instagram and email asking things about sexuality. And even though we certainly do focus on fertility, obviously, because we do IVF here at CNY Fertility at all of our locations in upstate New York, here in Colorado Springs, and at our other monitoring centers as well, supporting the mission of IVF and helping folks to get babies. We still do reproductive endocrinology, and it is all about human reproduction. And my background before coming here to CNY was really in gynecology and sexual medicine, and I still have that side practice as well at Cheyenne Mountain Gynecology here in Colorado Springs. So helping folks to be more productive centrally, sexually, is something that is part and parcel to what we do. And it's interesting because when I first came here and was talking to my one of my colleagues, we talked about sex and why in this population it's something that typically is not talked about. And by this population, we're talking about the fertility population. And I think the answer to that is perhaps that for many people, sex has the answer that I got anyway, sex has failed you. That it has been about trying to reproduce, about trying to have a baby, but has been unsuccessful. So for many people in that circumstance, it creates a situation where sex is uncomfortable, not only to participate in, but to talk about, because it has resulted in what is perceived as failure. And when that happens, it certainly takes the fun out of human reproduction. When it is a negative incentive to procreate because it isn't working, then that really makes one want to avoid the intimacy that's involved with reproduction. And so I certainly understand that. And in folks who are struggling to get pregnant, when you get a period at the end of the month, it's almost like that's a failure. And so those things that led up to you having that event may make you feel less inclined to want to participate, that the intimacy is no longer comfortable, but rather is a negative reinforcement. And I will say that that is learned behavior. That's something that we teach ourselves. And in fact, much of what we know about sex is what we either teach ourselves or what we are taught, not only as children and growing up with our parents, but in school. The messages that we get in school that are oftentimes very contrary to what we see when we're watching movies, when we're watching television. Because, on television, everything in a sitcom, it's all this sexual innuendo. And in every movie that you go to see in the theater, you would be led to believe that everyone is having the most amazing sex except for you, that something about you has made it different. And I have certainly been told by a lot of the male partners involved in couples that are in heterosexual couples who are reproducing, that they too start to feel like that it just stops becoming fun, that there's a need to perform, that here we are at a specific time during my cycle, and we have to do it because this is the time when we're going to get pregnant. So we need to be doing it. So come on, perform. Well, erections don't always work that way. And that can also lead to, when they don't work that way, that can lead to other issues that will continue to repeat and cause difficulties with the couple being able to have sexual relations. So the first question is, what is that intimacy? What is it? Intimacy is that connection that we have with another individual. And in the case of a partner with whom we are trying to procreate, that connection is incredibly strong. It's incredibly close, and it involves some very personal things and some very personal times. So that intimacy is critical to ourselves as humans. Why does sex feel good? Why does it feel good? Why do we do it? Why does it feel good? Well, it's certainly supposed to feel good, and certainly in some people it doesn't. So those who have pain syndromes, and we'll talk a little bit about that. I've already had a couple of questions here about pain syndromes. It's supposed to feel good. Why? It's a little gift from evolution to make us want to procreate. So the first question I got that made me think that this would be a good topic to talk about had to do with the female orgasm. And the question is, does an orgasm prior to an embryo transfer improve outcomes? Well, it's an interesting question, and it has actually been looked at. It's been looked at for people who are doing IUI or artificial insemination. There is some evidence to show that an orgasm may be beneficial prior to doing insemination. Why is that? Well, so first of all, what is an orgasm? It's the act of, it's something happening in the body that feels good. It's a little tidbit. It's a little treat that's thrown to us by evolution to again try to get us to procreate. I imagine that somewhere in the evolutionary scale, the female orgasm contributed to something with sperm being able to enter the uterus and perhaps be modal up into the fallopian tube. So, what is that orgasm? It is the act of stimulation to the point where there is swelling, there is vascular congestion. The blood vessels that supply the pelvis become engorged with blood, which increases which certainly has some effect on increasing fertility. And it's that engorgement or that flow of blood that's going to the reproductive organs that may have some benefit to actual procreation when sperm and egg are trying to come together. So as the congestion of the blood vessels increases, the uterus and the pelvic muscles will start to contract in a pleasurable way. That contraction is mediated by two different hormones. The first is dopamine. Dopamine is our feel-good hormone, but the other hormone is oxytocin. And for any of you who have ever had a baby before, if you've been on labor and delivery, you might have gotten oxytocin through the intravenous to supplement your labor because oxytocin is the hormone that causes uterine contractions. Now, the contractions associated with labor pain are certainly different than the contractions associated with orgasm, and most people would probably prefer to choose the orgasm route rather than the labor contraction route. However, it's the same hormone, it's oxytocin, which is also called the love hormone or the cuddling hormone. So in some folks who have a difficult time in achieving an orgasm, using intranasal or nasally sprayed oxytocin that we have made for you from a compounding pharmacy can aid both in libido, so sex drive, as well as in the strength of those climax type contractions. So as the uterus is contracting, that may have some effect of, in nature, pulling sperm to the inside. So is there some benefit to it? I would certainly say there is no detriment to it, and there is some evidence that shows that the increased blood flow that's associated with orgasm may benefit specifically in the use of artificial insemination. Now, people have also asked about, is there a difference between the clitoral orgasm and the vaginal orgasm? And I will submit to you that after at least 2 decades of gynecology, that there are many people who will have no idea what you're talking about if you talk about a vaginal orgasm. So the vaginal orgasm is said to originate from an area that's called the G-spot, which would be in the upper portion of the vagina. And it kind of makes some sense as to why it might be there. If there's a natural source of endorphin, endorphin is our feel-good chemical. So we know about endorphins, the runner's high, for instance. There's a flood of endorphin that happens after someone goes for a good run. If there was something endogenous, something in our system that could increase endorphin or the feel-good chemical as the baby's head was passing through the birth canal, it makes some sense why an area of nerve might be there. But I will tell you, it is controversial. And why is that? Well, the clitoral orgasm, most people can relate to. Certainly, many people will know what we're talking about if we bring it up. But the clitoris, if we go into the anatomy lab, is something that we can point to. It's something that you can dissect out theoretically and hold in your hand, but the G-spot is not. The G-spot is not something that we can actually dissect and hold in our hands. So many people will say, well, it doesn't actually exist. In some people, it is more developed than in others. In some people, it can be stimulated more easily than others. In many people, and certainly in the unaroused state, touching this area, which we think of as the G spot, feels just like you're pushing on the bladder because it is on the underside of the bladder. And so it may not really do very much. I don't think, in terms of reproduction, whether there is a big difference between the clitoral orgasm and the vaginal orgasm. That said, there are, of course, all manner of implements that one can use to assist themselves in achieving an orgasm, and so certainly in nature, and for folks who are trying at home, I would encourage the ability to at least attempt an orgasm, because what that does is that it increases the blood flow to the pelvis, and again, that certainly can't be a harmful thing. The other question that I got with regard to sexuality had to do really with about the shape, or rather the position of the uterus. The position of the uterus. So you may have been told about that your uterus sits forward, that it's anteverted, or that your uterus sits backwards, it's retroverted or retroflexed, or that it's mid position. Many people, so the sensation that's associated with your uterus under various conditions, both sexual intercourse, also with the kinds of cramps that you might get when you have a period, can be related to that position of the uterus. But it shouldn't have anything to do with your innate ability to get pregnant. So some people are right-handed, some people are left-handed. Some uteruses sit forward, some uteruses sit backward. The sperm still knows where to go. Sperm swims in through the vagina into the uterine cavity. And from the uterine cavity, sperm swims into the fallopian tubes. And that's where the sperm meets the egg. So the ovary releases the egg when you ovulate. The egg is taken up by the portion of the fallopian tube that's called the fimbria. And the egg is brought into the fallopian tube, and that's where sperm and egg meet. And that's where our embryo is created in nature. Now, of course, in the IVF world, our embryo is created in the laboratory. But in nature, that embryo takes place in the tube, and it floats its way down and implants inside the uterus. Does the position of the uterus, does a retroverted uterus, for instance, make a difference in terms of ability to implant or for sperm to get where it needs to go? And the answer to that is no. The other question I got had to do with male sexuality. So, of course, male sexuality is a little easier, seems to be a little easier to talk about in our society, and that's probably because you can watch TV at night and see TV commercials for the pill that you take to help with an erection. So most men who will have difficulty with sexuality, it has to do with erectile dysfunction. Most erectile dysfunction is psychogenic in nature, with a secondary component being the blood flow, again, that's going to the genitals. So it's psychogenic in that once it happens one time, it typically becomes something that the man will think about and worry about ad nauseum, on and on and on. And the more you think about it and the more you worry about it, the more likely that same thing is to happen again. So the easiest way to get around that is certainly to realize it's something that happens to almost every man. There's nothing that's abnormal about it, but especially worrying about it or thinking about it is enough to make it recur. Now, using a medication to increase the blood flow to the genitals can be one way to overcome erectile dysfunction. The other thing that happens in men is premature ejaculation. And that's when the ejaculation happens before the couple is ready for it to take place in a satisfactory way. Now, in terms of reproduction, evolution would say, well, the quicker that he ejaculates, the better off you are, because then he has a greater probability of being able to share his seed such that the species can perpetuate. So from an evolutionary standpoint, premature ejaculation isn't a problem. It's really only a problem to people's ego and to people's satisfaction with their satisfaction with their intercourse. There are some ways around that. So typically the reason it happens is because of, as you might imagine, it's overexcitement results in rapid stimulation to the point where ejaculation takes place. And in many men, this will happen before they're ready. But when will they actually be ready? For some men, they would say, I'm not ready until 30 minutes into the act. Whereas the female partner might say, I don't think I need that much. Thank you. So typically it's thought of in under a minute or in 30 seconds or so. And again, from a reproduction standpoint, that's not a problem. There are some commercially available products that men can use to try to delay ejaculation. Many of those products now are 100% available in Walgreens and CVS. KY makes a product that is a delaying cream. There's a delaying gel, just like there is a warming gel, and there is another gel that's designed to increase female sensation. Typically what these creams contain is a numbing medicine that's called lidocaine. And when applied topically, lidocaine can diminish some of the sexual sensation. It's applied typically around the base of the penis, around the glans portion of the penis, which then allows for movement from the male without excessive stimulation. The downside to using this medication or using this product is that somebody can use too much. And if you use too much, then it delays ejaculation inevitably till the point where you just no longer feel like trying. It just, you can't actually get there. And that's a different kind of problem. So how do you handle that? You taper back, you use less medication. There are a number of other products that are available. There is in East Asian medicine and Chinese medicine, there is a product, an herbal product that is also placed on the penis around the base that works exceptionally well. Although, to be honest with you, the KY product is easily available really in almost any kind of drugstore. So that's kind of some basics of how we think about things. And meanwhile, I got a couple of questions here I'd like to point out. We'll certainly try to answer your questions about fertility tonight as well. But if you have any thoughts or questions about things related to sexuality, then please feel free to throw them in here. We're all amongst friends. Please don't be embarrassed to talk about these things, because it is our inability to talk about them that makes them problematic. So let's see what we have here. Can we talk about when it's painful and ways to improve pain, or things to consider as well? So painful sex is a very good reason that people don't want to have sex, and it can happen for a number of reasons. And one of the things I've always told male partners, or even female partners of those who suffer from sexual pain syndromes, is that there's only so many times that I can poke you in the eye before you start to turn your head away when you see that finger coming towards you. And you may extrapolate that with any metaphor or anatomic part that you would like to use there. If it hurts, it's going to be a negative disincentive to keep doing it. And so you're not going to want to keep doing it. So one of the most common situations that happens is with a condition that's called vaginismus. And vaginismus is when the vagina literally slams itself shut. It flinches because it senses that pain is coming. So, in my world of gynecology, sometimes I can't even place my small finger in someone's vagina because of the muscles clamping shut. So, you can imagine what that must feel like and how that must stand in the way of a couple who is trying to have sexual relations. I have seen this really countless times. A lot of times, it actually happens with couples who have not been sexually active together before they get married, and then they end up getting married only to start trying to have intercourse, just to find that it's way more painful than it was ever cracked up to be. And then you go back to, again, the TV shows and the movies, and it looks like everybody's having sex all the time. And then you think, except for me. And that just makes the pain all the worse. You start expecting the pain. You start thinking everybody else can do this but me. And that makes that pain syndrome worse. There are different medications that we can use to treat vaginismus, but probably the most effective treatment is what's called pelvic floor physical therapy. And pelvic floor physical therapy is where we can actually teach you to be able to control the muscles that you normally have no conscious control over, such as the muscles that surround the urethra, for instance, or those that are in the muscle in the vulva surrounding the vagina, or the organs on the inside, or rather the muscles on the inside that seem to be slamming shut. Very effective to treat that with pelvic floor physical therapy. So that's vaginismus. There's another syndrome that's called vulvodynia. Vulvodynia means quite literally painful intercourse, rather painful vulva, a painful vulva. I just noticed over on Facebook, my friend from Miami, Randy Hill, says, "What? No airplane talk?" Well, if you know, I'm a pilot and certainly always like to talk about airplanes, but talking about sex, Randy, is probably just more interesting at this point. So we can talk about airplanes later. Glad to see you. We were saying, I'm sorry, I just got sidetracked by Randy Hill. Thanks, Randy. Vulvodynia is a situation where it's literally a painful vulva, which can come from any number of things. One of the most common presentations of vulvodynia is actually in someone who at one point had a yeast infection. And that yeast infection caused the sensations that you associate with a yeast infection: tingling, itching, burning. And maybe the yeast infection goes away, but the sensation doesn't. The nerves are turned on and they don't stop. So it wouldn't be uncommon that I might see a woman come in who might come in to see me with a book of every time she's been treated for what she believes is her chronic yeast infection. But in fact, in that 100 times that she's gotten medication, in fact, there was no yeast infection at all. It's that the nerves are thinking there's a yeast infection, but really there isn't. So imagine what that feels like, that you touch the stove and you say, "Ow, that's hot," and you pull your finger away. Well, what happens if you feel that stove no matter where you are? You're walking down the aisle in the grocery store, you're driving in your car, you're sitting at work, you're constantly thinking you're touching the stove. That would be torture. And so that's really what that form of vulvodynia feels like. And that has a term. We call it vulvar vestibulitis. And there are newer terms for it, but most gynecologists will understand what vestibulitis is. We can treat that very effectively now as well. It used to be systemic treatments were the only way, but now there are topical treatments that we can get made through compounding pharmacies that are very, very useful. Pain on the inside is called dyspareunia. Dyspareunia means painful intercourse and can happen for any number of reasons anatomically, maybe from some scar tissue, maybe just simply from having a full bladder during the active intercourse. Endometriosis, which is common in our fertility population, is also a reason that folks will have pain with intercourse, and often also pain, certainly pain with periods, and even pain with defecation, pain with the bowel movement. Those are some of the questions that we ask to try to narrow down. Could this be an issue of endometriosis? So pain on the inside is something that's worth talking to your doctor about so that we can try to localize where the pain is coming from. Sometimes it may be something as simple as a position change. Because one of the common things that I would see in my practice is pain with intercourse that's related to hitting the ovaries, literally banging into the ovary. If the ovaries are so close to the vaginal wall, so close to the lower portion of the pelvis, that during the active intercourse, they are literally being traumatized. It's easy for a male partner to understand that because it would be the same thing as taking a testicle and going, How many times do you think you're going to be able to do that? It's probably going to end pretty quickly. So in that situation where it's due to the presence of the ovaries just being in a bad spot, which can be related to how full the bladder is. It can be related to how much gas is in the bowel at the time and the status of the bowel and the rectum. Simply a position change or using some extra lubricant, moving over, choosing a different way to have insertion can be a solution to that. As I say, it's pretty easy for your doctor, your provider, to be able to localize where that pain is coming from and to make some suggestions about how to fix it. Let's see. I saw some other questions over here. After a successful embryo transfer, and this comes from Tiffany. Hey, Tiffany, glad to have you with us here. By the way, if you're just joining, it's a little half past the hour, 4:33 in the Mountain Time, so 6:33 on the East Coast. You're on Fertility with Fink and Friends from CNY Fertility in Colorado, and I am Fink, and you are friends. So we'll try to stay with this for just about another half an hour if we can. If you have questions, we're talking about intimacy and sexuality tonight, so please feel free to throw them my way. And if we have some time to get to these fertility questions here as well, we will certainly do that as always. So Tiffany says, after a successful embryo transfer, when can you start having fun again? I'm worried and keep telling myself there is no need. Well, I presume, Tiffany, the kind of fun that we're talking about is the same kind of fun that we're talking about here tonight. So I was thinking, well, you can go have fun right after your embryo transfer. Go get some, go to McDonald's and get your French fries. That's fun, right? I don't think that's what you're thinking about. So usually we tell folks to take it easy for 2 days after an embryo transfer. And in reality, that implantation can take place up to 5 days after embryo transfer. There's no hard and fast rule. There's no data to support when you can resume sexual intercourse after an embryo transfer. But in general, I would tell folks after a week, that should be safe. Now, you said after a successful embryo transfer, so I'm presuming that means you got pregnant. When can you have sex when you're pregnant? Can you have sex when you're pregnant? Oh my heavens. Can you do that? I don't know. I should ask Dr. Kiltz about that. Yes, of course you can have sex when you're pregnant. So oftentimes, as pregnancy continues and the pregnant belly gets larger, it may mean some logistical changes in how you're going to have sexual relations. But whether your partner is a male or a female, sexuality and orgasm after pregnancy, or I should say during pregnancy, is generally speaking completely fine. Now, there are some conditions in pregnancy that may preclude that. So there's something called a placenta previa. So if you remember in last week's episode, we talked about a low-lying placenta. And when our nurse friend Kayla was here with us, we demonstrated about a subchorionic hemorrhage and about a placenta previa, a low-lying placenta, and how the placenta often moves as the pregnant uterus gets larger and larger. Well, a placenta previa happens when the placenta stays over the opening to the cervix. So if that's the case, you can't deliver vaginally under that circumstance because the placenta is in the way and all your blood is flowing through you, going through that placenta and going to your baby. So that would be an extraordinarily dangerous thing. Well, when we know that you have a placenta previa, we also say no vaginal exams. No vaginal exams because we don't want anything to touch that portion of the cervix, and that is certainly goes with sexual intercourse as well. We don't want anything in the vagina in the face of a placenta previa. So let's see what else we have here. Lots of folks being with us. So this is a non-sexual question, and that's okay too. Can we share experience as it pertains to ovarian PRP and also with Zymot? I just heard of these two offerings. Are they as promising as they sound? PRP is platelet-rich plasma, and platelet-rich plasma is when we take a portion of your blood and separate out your healing components. That's the part of your blood that has growth factors, tissue factors, healing factors. And we actually place that directly into your ovaries. That's done typically in our office. Intra-ovarian PRP is usually done under some anesthesia with a needle going into the ovary that's ultrasound guided. So in many ways, like we do during an egg retrieval. And that may have the ability to improve one's egg quality. Now, there's not a lot of great data to support it because those are hard things to study. But I will say that empirically, in our experience, it does make a difference in women with diminished ovarian reserve or with issues of egg quality. So we do encourage it. Zymot is a sperm preparation device that helps our embryologists and andrologists select the best sperm to use for fertilization. If you believe Zymot's literature, which is all pretty much performed by the people at Zymot, it's a wonderful, amazing thing. It's still considered experimental. It is an add-on that you can pay for to use. I have not found that it is as useful as they would like for it to be, but I will tell you that it's a $200 add-on. It's not a $2,000 add-on. So is it going to harm anything? Probably not. The only concern there is that I see I've got a line down the middle of my face here. I'm going to try and move out of the way. The only concern is you have to have a certain number of viable sperm. Your sperm count has to be high enough, and there has to be enough of them moving, or what we call motile sperm, in order for Zymot to be effective. And so some people come asking for Zymot, but are unable to use it because of that issue. So waiting on baby Willie over here, who came from my Facebook page. By the way, thanks for everybody who's with us on Instagram. I said Facebook, I meant Instagram. If you don't follow my Instagram, it's Randy Fink MD. And of course, those of you watching on the CNY side, CNY Fertility. And we're on the CNY Fertility Facebook as well. Waiting on baby Willie says, what if he can't get there all the time? So I think that means what if the male partner during sexual intercourse is unable to ejaculate? Well, we talked about rapid ejaculation or premature ejaculation. So what about the other end of that spectrum? What about delayed ejaculation? And that happens to some folks as well. Do you know, any idea what is the most common reason in a male for delayed ejaculation? Certainly not the only reason, but the most common reason. Any idea? I'm waiting for you to answer. I'm like listening. Nobody's saying anything. The most common reason is because of antidepressants. So the SSRIs, the selective serotonin reuptake inhibitors, and these are drugs like Prozac and Zoloft and Paxil, all of the really most of the current drugs that are used as mainstream antidepressants have the potential to delay ejaculation. In other words, what happens is, and this happens in women as well, the time period from arousal to climax just extends and extends and extends and extends and extends to the point where you may just kind of give up and say, I just don't think it's going to work this time, so not going to happen. Most commonly, that's an SSRI, and that is also something that we can overcome with intranasal oxytocin, because oxytocin, again, the love hormone, the cuddling hormone, which also helps with libido, will take that interval from arousal to orgasm and bring it back closer again. So that's something. Now, every gynecologist will not know about that. It's really something that we practice in sexual medicine or in functional medicine gynecology. So a functional medicine doctor will know about that as well. That's one reason, and there can be some anatomic reasons as well. But rest assured that the secretion that comes out of the penis during arousal, which typically is a secretion that comes from a gland that's called the Cowper's gland, and there is a common name that you may know of for that secretion, usually has some sperm in it as well. So there is some exposure to sperm in the vagina, even if the man doesn't overtly ejaculate. So that's something that we always want to tell our high school age kids, but certainly something to know in the fertility world there as well. My dear friend, New York baby DJ, hello. I told you I was going to say hello to you, so hi. What about the Mona Lisa? So that's a very good question. Mona Lisa Touch is a laser procedure that is used to treat typically the menopausal vagina. It's also used in treating the some women in the postpartum period, especially breastfeeding, because when you're breastfeeding, your estrogen levels will be lower than normal, and those lower than normal estrogen levels can lead to vaginal dryness. What the Mona Lisa treatment does is that it uses a form of laser to stimulate the growth of new blood supply, new skin, new nerve supply in the vagina, and in many ways can make a vagina that is not estrogenized, particularly associated with menopause, function as though it were a much, much younger vagina. It's a very effective treatment, and I very highly recommend it. Here is a fertility question. Are there any benefits to Orilissa before retrieval versus before an embryo transfer? Well, Orilissa is a medication that's used to treat endometriosis. And what we know about endometriosis is that, so endometriosis, of course, is the process where the normal lining of the uterus, which would slough off and come out during your menstrual period, instead of coming out, works its way up inside and implants within the abdominal and pelvic cavity, and can cause scarring and can cause a pain syndrome. Painful periods is the most common presentation with endometriosis, but also with more severe endometriosis, with what we call stage 3 and stage 4 endometriosis. That tissue starts to interfere with the way the brain is talking to the reproductive system, right? So the brain talks to the reproductive system with hormones, right? And so that tissue, that endometriosis, can sort of stand in the way of that electric signal that's coming from the brain to talk to the reproductive system. So that's one of the ways in which endometriosis can affect fertility and certainly in embryo transfer. So I'm not aware of any data that shows us that using Orilissa to treat endometriosis before a retrieval of your eggs is necessarily beneficial to egg quality or into the number of eggs that we're able to retrieve. However, the data is pretty clear that with stage 3 and stage 4 endometriosis, using that medication for typically about 2 months prior to an embryo transfer can improve the outcome of an embryo transfer. So hopefully that answers the question there. Can you do the Mona Lisa if you're on pellets at the same time? The answer is yes. So hormone pellet therapy is another way that we can fix or balance people's hormones. Pellets are like little grains of rice that go under the skin. Then in a woman, will last for about 3 to 4. Well, they say 3 to 5 months, typically about 4 months, I would say. This is one of the brilliant ways that we can also address libido. So for folks who have a difficult time with sex drive. Now, female sex drive is a very complicated matter because there are so many things that can go into it. And that is probably a conversation for a different time. But treating with testosterone is one of the things that we can use to affect libido. And certainly pellets are a great delivery system for hormones in women who are menopausal. And yes, they can be done with the the Mona Lisa. Do we have thoughts on intralipids? Thanks, M. Pinner. Appreciate that question there. It can be expensive, and sometimes it's hard to find a place to you locally who can do the intralipid for you. Intralipid is like... Intralipid is kind of akin to doing an IV version of the keto diet. So an IV version of keto. And if you listen to Dr. Kiltz, keto carnivore is a very important thing. It's very anti-inflammatory. So highly recommended if you can. And so that's really what the intralipid does. If you can do the intralipid, I think it's definitely worthwhile. Certainly at least to do a dose of intralipid on your day of transfer, or at least the day before transfer. So here at CNY Colorado, we do offer that service on both day of transfer and kind of right before. So please do think about that. And thanks so much for that question. We've got about 10 more minutes here. So let's try to get to a few more questions if we can. Are lubricants okay when trying to conceive, or are they sperm killers? And that's a great question too. In general, when you come here to the fertility office and we're going to do an ultrasound. So there is a vaginal ultrasound probe that has literally a condom over it. And there is some jelly, some ultrasound jelly that is inside the condom. So between the ultrasound probe and the condom and then your body. That ultrasound jelly is necessary for us to be able to have an interface so that the ultrasound equipment is able to see inside of you. But you'll notice we don't use lube on that probe. Why not? Well, we just don't want it to be there. So now even the water-based lubricants, so that's things like KY, or AKY, of course, being the most common, are said to be safe. But given the choice, I would say try to avoid lubricants if possible when trying to procreate, when trying to have a baby, because those lubricants can act. They may not be sperm killers, but they may be sperm inhibitors. Now, there certainly are some kinds of lubricants that are sperm killers. And so, and for instance, that's one of the common lubricants that's on a spermicidal condom. But obviously, if you're using a condom, you're probably not trying to get pregnant, or at least trying not to get pregnant. So how about a tattoo before or after doing an FET, or should we wait? Do you know that the most common reason that Americans in mid to upper socioeconomic classes will become pregnant is, I'm sorry, the most common reason that these people will develop hepatitis C is due to a tattoo. So it's not that tattoo parlors are dangerous places, and when disease is spread, it is inadvertent. It is not something that, certainly not something that is intended. But in my opinion, I would avoid getting a tattoo just around the time of an FET, or even during, certainly during pregnancy. And in fact, many tattoo places would not want to do a tattoo for you if they knew you were pregnant. Some of them will, but I think it's probably better just to wait. Now, again, I don't want to sound alarmist and that, oh my goodness, getting a tattoo, that's going to give you hepatitis. Fortunately, it's really not all that common. The most common reason that folks end up with hepatitis C has to do with intravenous drug use. However, in the non-drug using population, the most common source comes from tattoos. And so that's something that you'd certainly prefer to avoid when you're pregnant. So again, great question. Thank you for that one. Let's see. When prescribing and using, let's see, is it normal to only have an orgasm with clitoral stimulation? Never had an orgasm the other way. I would say yes. And again, like we said before, there are many people who will tell you, I don't know what you're talking about when you're talking about a vaginal or a G-spot orgasm, because I've just never had one. I do believe that the body can be trained to be aroused from a non-clitoral place, we'll say, for Instagram's sake. The body can be trained. You are not alone if you've never had a vaginal orgasm, because again, many people just haven't developed the nerve supply to be able to experience it. And if you think about it, if you think about the clitoris as a wall plug, well, you would agree that if we took a screwdriver and we took the little screw out of the wall plug and then we started pulling on the plug, there's a bunch of wires behind the wall, right? Well, those wires are nerve supply. And where does that nerve supply coalesce? It coalesces right at the place that we know of as the G-spot. So when we do a procedure, for example, that's called, there is a procedure, it's a trademark name, and so I will give due credit to the trademark, called the O-shot. When that procedure is performed, and that's when PRP is placed into that area of the G-spot, that nerve supply can be bolstered. So that's kind of how the way to think about it. To think about it anatomically. Now, here back to a fertility question. When prescribed and utilizing estrase and prometrium vaginally during IVF, are there any precautions that need to be taken when being intimate with a partner? Well, I thought that was a fertility. That's a good sex question. You know what? Thank you for thanks for asking that. The answer is probably not. When there's estrogen and progesterone in the vagina, it's going to be exposed to the other person's sexual organ if it is inside. Is that going to have some sort of negative or adverse effect on them? In the short term, the answer is no, probably not. Now, as you know, if you've done any of these intravaginal medications, they make a mess. Right? They aren't always pleasant to use. They aren't always pleasant to kind of have around, even, for yourself. So that's the only thing to kind of keep in mind, that it may kind of turn out to make things a little bit messier. But does it have a negative effect, or is it dangerous for, let's say, a male partner, for instance? The answer is no. For a female partner, is it dangerous? And the answer, again, fortunately, is no. Those are the same hormones that the female has. And greetings from Miami there as well. Thank you. It's so nice to see the sunshine here around. Gosh, we've got just a couple more minutes. So I want to say, yes, you can throw a question here, or you're welcome to ask them on Instagram. Again, that's Randy Fink, MD. Gosh, I want to say, here's the last question I want to be able to answer here. Can you use Clomid to improve sperm even if testosterone levels are normal. Clomid will increase a sperm count. So it is something that we use for lower sperm counts and for male factor infertility. Clomid will also increase a male's testosterone levels. So if a man came to me with a testosterone issue, for instance, the first question I want to know is, are you trying to get pregnant, or do you have a pregnancy in your future? Because if so, we don't want to give you testosterone. If we give you testosterone, the same cells that make sperm are the cells that will make testosterone in the testicles. And we are fundamentally lazy creatures down to the cellular level. So once we start to get some testosterone from someplace else, our body will stop making it. And as a result, we'll probably also stop making sperm, or at least significantly diminish that sperm. So in that person, use of Clomid is probably a pretty good idea, because it can bring up both his sperm count and his testosterone level without having a negative effect. Well, folks, it looks like we're going to have to call it quits here as we approach the top of the hour. But as always, I want to say thanks so much for joining here with Fertility with Fink and Friends from Colorado Springs. Again, join me on my Instagram or come back here every week. We usually will try to bring in a special guest or have some thought-provoking and interesting topic. But our goal at the end of the day is to make sure that you have the family that you want, and that anything that we can do to help get you there is really what we're here for. So again, thanks so much to all of you for being here. God bless. Be safe, and we wish you well. Good night.